stayed on as one of our cardiology fellows for 3 years, and then spent a year at MGH with one of my friends and co-fellow from years ago, Tom Nealon, to study cardio-oncology. During the year, she's extremely productive academically with numerous high-quality publications on cardio-oncology topics in journals such as Circulation and European Heart Journal. We're very happy she decided to come back to Montefiore to lead the cardio-oncology initiatives in clinical care as well as in research. Now I see we have 20 plus attendees. I would like to take the opportunity to give everyone here a quick Chinese lesson, okay? The correct pronunciation of Lili's last name, Z-H-A-N-G, is Zhang, okay? Is Johnny Cash, Zhang. So 7% of the Chinese population has a last name, Zhang. We have Zach Zhang, first-year cardiology fellow, and Andy Zhang, our new EP attending. So next time, if you pronounce this name correctly, you get a little gold star. On that note, the floor is yours, Lili.
Thank you very much, Dr. Taub. Good afternoon, everyone. I'm so fortunate to be trained in this great institution, and now I'm very proud and I feel even more fortunate to start my career here with many beloved mentors, colleagues, and friends. I appreciate Dr. Garcia and Dr. Taub for giving me the opportunity of working on cardio-oncology. So today I will take the next 45 minutes or so to first introduce our cardio-oncology program by talking about some basics, surveillance and management of chemotherapy-induced toxicity. And then I will also spend some time to focus on immune checkpoint inhibitor-induced cardiotoxicity because I think it's an important topic in the current era of cancer treatment. Now, hopefully I can leave some time for the questions. So we all know that cancer and cardiovascular disease are the two leading causes of death in the United States. And the advancement of cancer therapy has led to decrease in cancer mortality, and cancer survivors have much higher risk of cardiovascular disease than general population. They have 15-fold increased risk of heart failure, 10-fold higher rates of coronary vascular disease, and 9-fold higher rates of stroke. And this heightened risk is due to numbers. It's multifactorial, but most of us believe cancer and cardiovascular disease has many shared risk factors, such as aging, smoking, inflammation, etc. And on top of that, cancer therapy itself can cause various toxicities in these patients. Nowadays, there are over 15 million individuals with a history of cancer alive. And by 2026, there will be an estimate of 20 million survivors. And cardiovascular disease has become the leading cause of long-term morbidity and mortality among cancer survivors after secondary malignancy. Childhood cancer survivors also have increased risk of cardiovascular disease, and also they can suffer from cardiotoxicity as well. So greater than 80% of children treated for cancer become long-term survivor. In 2013, approximately 420,000 survivors of pediatric cancer in the US, and by 2020, it will be 500,000. The cardiac mortality in childhood cancer survivors was 7-fold higher compared to age-matched population. For children cancer survivors who got secondary malignancy, the risk will be even more intensified as they will receive the cumulative use of cardiotoxic therapy, as well as radiation therapy. So this map shows that there are 30 plus cardio-oncology clinics in the US by August 2016. This is by Google search, so it's not that scientific. But in the past few years, the number of program has grown rapidly. I would not be surprised if the numbers of clinic has doubled as of this year. And we can also proudly add a monitor to the map. So this slide summarizes the varieties of conditions we can cover in the cardio-oncology clinic. The major one would be heart failure, cardiomyopathy of various stage, secondary to anthracycline, HER2 agents, VEGF signal pathway inhibitors, proteinase inhibitors, and immune checkpoint inhibitor that I will be talk about later on in the presentation. There are also hypertension from TKIs, peripheral arterial events, thrombosis from also small molecule TKIs, and coronary artery disease from chest radiation and aromatase inhibitors. Valvular disease, mostly from chest radiation that we're familiar with. And there are DVTs and thrombosis from solidomab and etc. Atrial fibrillation is the most common arrhythmias in cancer survivors, and ibrutinib is a big offender of that. And in our institution, Dr. Torres is the expert of cardiac amyloidosis, so that is in his territory. The cardiotoxicity is really multifactorial. There's few players in this map, including pre-existing cardiovascular risk factors and cardiovascular disease, cancer treatment, a host interaction, and cancer treatment related cardiotoxicity. And the involvement of cardio-oncology really should start from the beginning when the cancer was diagnosed. And we can give patients a good, thorough baseline assessment about their cardiovascular risk factors and cardiovascular disease. And this is particularly pertinent for the Bronx population, where the cardiovascular risk factors is usually not controlled well and very prevalent. And we can get actively involved in monitoring the occurrence of cardiotoxicity during cancer treatment. And in the survivorship, once the cancer treatment is completed, some of the patients can develop late cardiotoxicity, especially for patients on anthracycline and radiation therapy before. So anthracycline was really started to be used very commonly in the cancer treatment world in 1916s. In 1971, the dose-dependent anthracycline-induced cardiomyopathy was first described in 67 patients. And the mechanism is quite complicated and it remains unclear. Some studies suggest a generation of reactive oxygen species to be part of the pathogenesis. And some other studies suggest that the cardiotoxicity is mediated by the topoisomerase 2 beta in the cardiomyocyte, which lead to cardiomyocyte damage and death. And for trastuzumab, which is very commonly used HER2 therapy in breast cancer patients, in 2001, the combining trastuzumab with anthracycline caused heart failure in up to 27% of patients in the pivotal clinical trial was reported. And this is in comparison to 7% in anthracycline treatment alone. This is a study done at MD Anderson early 2000, beautifully demonstrated the doxorubicin dose-related toxicity. So on the top panel, we can see that doxorubicin-related heart failure. This is clinical heart failure. The risk is really started to increase when the dose reached 300 milligram per meter square. And there are two curves on the top panel. We can see that the dash represent patient with advanced age of 65 years or older. We can see this curve is much steeper compared to the patient with younger age, which suggests advanced age is a major risk factor of doxorubicin cardiotoxicity. And on the bottom panel shows doxorubicin-related cardiovascular events. We can see that the cardiovascular events start to increase once the cumulative dose reached 150 milligram per meter square. So there's really no safe dose for this medicine. And faster forward, in 2015, investigators from Italy performed a study by assessing LV ejection fraction by echo every 3 months during active treatment and 1 year after treatment. And they also performed follow-up echo every 6 months in the next 4 years. This is in 2,600 patients with a median follow-up of 5.2 years. And in this particular study, the cardiotoxicity is defined as LV ejection fraction decreased by 10 absolute points to less than 50%. And the average dose of doxorubicin used in this study was 300 to 350 milligram per meter square. The overall incidence of cardiotoxicity was 9% in this study, and 98% of the case occurred within the first year. Looking at the figure on the right side, the square represent a patient with full recovery of the ejection fraction, and the triangle represent partial recovery, which is defined as greater than 5% absolute points increase in the ejection fraction to greater than 50%. In this study, 11% of patients had full recovery, and 71% of patients had partial recovery after heart failure treatment. This is a study done by Dr. Bonnie Key's group, assessing the detailed echographic parameters in 117 patients received doxorubicin, about 50 with trastuzumab and 50 with combination therapy. On the top, we can see the trend of ejection fraction change in these 3 therapy groups, with the orange represent doxorubicin alone, green represent trastuzumab alone, and purple represent the combination therapy. We can see that all 3 therapeutic group has a decline of ejection fraction, reached to the nadir around the mid first year. And then the ejection fraction start to recover. For trastuzumab alone group, which is the green curve, by the end of 3 years, the ejection fraction returned to the baseline level. But for the other groups, they were still lower than their baseline ejection fraction. And the bottom 3 curves panel represent the global longitudinal strain and their change over the 3 years of follow-up. Because global longitudinal strain is a negative number, so the positive change represents a reduction of the global longitudinal strain. So we can see there's a progressive reduction in the global longitudinal strain over 3 years of follow-up. It's a similar situation to circumferential strain and radial strain. But because radial strain is a positive number, so the figure is reversed. And also, the reduction of the GLS in these patients are actually associated with LVEF decline and worsening heart failure. I don't want to overload you with numbers, but this table is basically to give you idea that the instance of anthracycline toxicity and HER2 therapy toxicity. These are the two major categories we see in the cardio-oncology service. So you can see that the incidence is quite variable. This is because different studies may be using different agents, and the endpoint definition is very important, whether it's clinical heart failure or it's ejection fraction reduction, or it's a decline in the global longitudinal strain. I normally would inform my patient that for anthracycline use, for average risk patient in the Bronx, it's around 10%. And for HER2 therapy, if it's a combination with anthracycline use, the risk could be up to 25 to 30%. All right, so we talk about the cardiotoxicities caused by anthracycline HER2 therapy. Can we do anything about it? So there's a few randomized controlled trials have been done to investigate the primary prevention of cardiotoxicity. This is Overcome trial, which was done in 2013 from investigators from Spain to study 90 patients with acute leukemia. Patients were randomized to enalapril and a carvedilol group and a placebo group. So we can see that in the bottom figure, that the intervention group, the overall ejection fraction did not change for the intervention group. And for control group, there's consistent reduction in the ejection fraction in the 6 months of follow-up. More importantly, patients in the intervention group had a lower incidence of the combined events of death or heart failure with the p-value of 0.036 and the final ejection fraction less than 45%. And this is another study, a PRADA study, which is also done in Europe, assigned 130 adult women with early breast cancer with no serious comorbidities to cardamom and metoprolol-succinate. And in this study, we can see that on the bottom panel, that the use of cardamom is associated with, it's positively associated with change of ejection fraction, which is consistent across the subgroup analyses, except the right side radiation. And then for the metoprolol group, metoprolol-succinate group, the investigator did not observe any association between the use of metoprolol and change in ejection fraction. So the study concluded in early breast cancer patient with adjuvant anthracycline containing regimen concomitant to the treatment of cardamom provides protection against early decline in global LV ejection fraction. This is a study from US last year that it's a multi-center randomized clinical trial recruit 460 women with breast cancer to investigate lisinopril versus carvedilol to prevent transfusion cardiotoxicity in patients with breast cancer. So on the left side is the results in the whole cohort, which consists of 468 patients. There's no difference in the cardiotoxicity-free survivals between placebo, carvedilol, and lisinopril. On the right side, we can see this is trastuzumab and anthracycline combination therapy group, which consists of 189 patients. Cardiotoxicity-free survival is much improved in the carvedilol and lisinopril group in comparison to placebo. So this study conclude that for patients on combination therapy, that lisinopril and carvedilol can be beneficial in preventing cardiotoxicities. For most of the breast cancer treatment nowadays, these two categories of treatment are usually used in combination or sequentially. So I think this result is highly relevant. Just to summarize anthracycline-induced toxicity, there are 1 million patients treated with anthracycline worldwide, and some of the patients can have chemotherapy-induced cardiotoxicity in the first cycle that can lead to cardiac damage. 9% of the patients develop cardiotoxicity. 98% of the cases of cardiotoxicity occurs within the first year of treatment. And these patients have 15 times increased risk of heart failure in cancer survivors. And doxorubicin, I didn't mention that particularly in the study, but this is the only FDA-approved cardioprotectant. This is usually used when the anthracycline is being infused, so it's not that relevant to our group. This is figures, again, summarize anthracycline toxicity, that on the top, we can see there's multiple risk factors for these, including extreme age, whether very young or older age than 65, female gender, cardiovascular comorbidities, adjuvant chemotherapy, and adjuvant thoracic radiation therapy. There's different stage of anthracycline toxicity, from no cardiotoxicity to death. The patient will go through a subclinical myocardial injury, asymptomatic LV dysfunction, symptomatic heart failure, and refractory heart failure, cardiogenic shock. The diagnosis is based on cardiobiomarkers and LV ejection fraction. The preferred imaging modality is echo plus global longitudinal strain. Obviously, patient symptoms and signs are very important for clinical assessment. And for ACE inhibitors, plus minus beta blockers are effective in preventing cardiotoxicity, and more so in the treating patients when the ejection fraction starts to decline. And the change of the cancer treatment should really be a careful discussion between the patient, cardiologist, and oncologist, so that we can look at the overall picture of the patients and alternative, whether alternative cancer treatment is available. There are very promising trials suggesting statins can prevent anthracycline toxicity, and there's a few randomized controlled trials are currently running to test the effectiveness of statin in the primary prevention of cardiotoxicity. So we'll be able to see that results in the next few years. This is the protocol that I created for our program for the referral process for cardio-oncology. I consider the experience from MGH and some of the published protocol from MD Anderson. I think every patient that is going to receive anthracycline and the HER2 antibodies should have a very thorough baseline examination, including history, physical exam, EKG, EMP, troponin, echo with global longitudinal strain. These are the baseline assessments, very important for the patient when they develop myocardial symptoms to have a baseline to compare with. And if the patient have more than 2 of the cardiovascular risk factors and they're uncontrolled or have active cardiovascular disease, or their ejection fraction is less than 50%, or if they have abnormal troponin, they can be referred to the cardio-oncology. If their ejection fraction is greater than 50% and they have normal troponin, they can initiate the treatment. The cardiac assessment should be done every 3 to 6 months for the first year. Remember, 98% of the cardiotoxicity occurred in the first year. This is a critical period for us to monitor the occurrence of the cardiotoxicity. The assessment should be very thorough, include, again, physical exam, history, EKG, biomarkers, and imaging. And if the patient's EF is greater than 50% and have normal troponin, they can continue on this process until they finish their treatment. If their ejection fraction declined by 10%, this is absolute reduction to less than 50%, or if their global longitudinal strain decreased by 15%, which is relative change. And if they have normal troponin, they should be referred to cardio-oncology. And after this therapy is finished, the patient should continue to have a follow-up after with the troponin, BNP, echo with strain at this 3 months, 6 months, 1 year, and yearly follow-up 2 to 5 years to complete the surveillance. The next 3 slides, I summarize some other chemotherapies induced cardiomyopathy and other conditions such as coronary artery disease, valvular disease, arrhythmia, and arterial hypertension, thrombosis, etc. Again, I don't want to overload you with all this information because it's a lot. But just give you an idea that we do have a varieties of agents that needs to be watched and a varieties of conditions that we can see in our clinic. Now I'm going to just switch the gear to talk about immune checkpoint inhibitor induced cardiotoxicity. I think because this is a relatively new area that I just want to spend some time to introduce this to you. So let's start with a case study. A 69-year-old man with hypertension diabetes was diagnosed with a metastatic renal cell carcinoma. He was started with Avastin and atezolizumab. After 2 doses, he presented to the emergency room with shortness of breath. His EKG showed sinus tachycardia. Conventional troponin T was 1.25 nanogram per milliliter, and he remained stably elevated thereafter. On the top is his EKG, and he also went to a cardiac catheterization, which didn't show any obstructive coronary artery disease. And on the bottom, he had an MRI done, which showed the ejection fraction of 29%. There was no LGE in this MRI. And the patient quickly deteriorated and developed cardiogenic shock. He actually underwent endomyocardium biopsy, which showed he had lymphocytic myocarditis in this case. So this patient was diagnosed with immune checkpoint inhibitor associated with myocarditis. So to most of us, maybe immune checkpoint inhibitor is relatively new drug. So since the time of 19th centuries, harnessing the immune system has been recognized as a potential treatment of malignancy. On this figure that I was trying to demonstrate is the mechanism of immune checkpoint inhibitor. So normally T cells are capable to identify and destroy the cancer cells by recognizing cancer cells. However, this PD-1 is program death 1. It's one of the immune checkpoint there are proteins on the surface of the T cell that they can combine with this ligand on the cancer cells that suppress the immune response from the T cell. So cancer really becomes very smart. So they actually overexpress these PD ligands so that the immune response from T cells can be suppressed and they can evade from the immune system and become uninhibited and continue to survive. Immune checkpoint inhibitor are monoclonal antibodies to these immune checkpoints. For example, this red triangle represents anti-PD-1. Once it's combined with PD-1, this immune checkpoint pathway is blocked. So there's no checkpoint, the T cell activation will not be suppressed. This will lead to overreaction of the T cell and the immune system, which cause several troubles, as we can go over in the next few slides. So the use of inhibitors is really rapidly expanding in the past few years due to its very promising clinical efficacy in treating cancer, various of cancer. It was first approved in 2011, and then we can see that the approved indication in various of cancer type just grow exponentially in the next few years. And on the right side, this figure demonstrates expanding landscape of immune checkpoint inhibitor trials, and the size of the bubble will correlate with the numbers of trials. And as of September 2019, there were over 3,300 clinical trials initiated to evaluate the effectiveness of ICI, either as single agent or in combination with immunotherapy, targeted therapy, or traditional cytotoxic or radiation therapy. An immune checkpoint inhibitor, while it has wonderful cancer treatment effect, it can lead to various of immune-related adverse events due to the overreaction of the immune system. So we can see acutely can lead to colitis, pneumonitis, hepatitis, dermatitis, you name it. Every system in the body can be attacked by the overreacted immune system. On the right side, and myocarditis, very importantly, is one of the acute immune-related adverse events. And chronically, we believe ICI can lead to arterial inflammation, vascular inflammation, and accelerated atherosclerosis, and furthermore, cardiovascular events. So immune checkpoint inhibitors associated with myocarditis is not very common. It has incidence of 0.1 to 1%, but we believe the incidence is dramatically underestimated because in the past, the condition wasn't really recognized. And we probably only recognize the worst case scenario. The disease has very high rate of MACE. Here, MACE is defined as cardiogenic shock, cardiac arrest, and cardiovascular death, and complete heart block requiring pacemaker. So the rate of MACE is 40% in 3 months. Just think about it. In comparison, in myocarditis of other etiologies, the rate of MACE is usually 15% in 5 years. And this is 40% in 3 months. So it's dramatic. It's a fulminant course. But I believe in the very early cohort, we only recognize the sickest patient in this group. It's very challenging in diagnosing these patients. I'll go over it in a little bit. And the treatment is usually immunosuppressant with corticosteroid plus other immunosuppressants. And there are other toxicities related to ICI, for example, myocardial infarction, cardiomyopathy, accelerated atherosclerosis with the overall incidence of 2%. But this is also underestimated overall. So this is the first report coming out from the MGH group I was working at in my fellowship, which led by Dr. Tom Nealon. This is a collaborative effort from over about 30 sites across US and Europe with the collective case of ICI myocarditis, really empowered us to understand this disease entity. And we can see that the time from the start of ICI to clinical myocarditis is usually very early. Most of the cases occurred in the first 3 months. On the right-hand side, we can see most of the patients have a abnormal EKG on their presentation. They also have elevated troponin on their presentation, but a small percentage of patients could have normal in either of the tests. And surprisingly, the LVEF is preserved in greater than half of the patients. This is also very different from myocarditis from other etiology. And most of the patients also have elevated proBNP. So subsequently, we look at a global longitudinal strain in these patients. We can see that prior starting ICI, the cases, which are the patient who developed myocarditis later on, and the controls have similar global longitudinal strain to start with. We can see there's dramatic reduction in the global longitudinal strain in patients who developed myocarditis. But in in controls, their global longitudinal strain was relatively stable. And these are the patients on ICI, but it didn't really develop myocarditis. And also, we can also see that lower global longitudinal strain among myocarditis cases in comparison to controls, with the case being 14% and the control being 20%. The global longitudinal strain also have a prognostic implication. So we can see for patients with a GLS above 16%, there's no MACE occurred in 120 days of follow-up. And in patients between 14 to 16, we can see there's worse MACE-free survival. When the strain below 14%, the survival is worse in the group. MRIs is considered to be the gold standard imaging test for myocarditis. So how it is behaved in ICI myocarditis patients? Surprisingly, in our cohort, we only found less than half of the patients had LGE at all. This is also dramatically different from a myocarditis of other etiology, where we can see that maybe more than 80% of the patients had LGE. The patterns of LGE we found in our cohort is also variable. As I said, more than half of the patients have no LGE at all. Some patients have transmural LGE. Some patients have epicardium. Some patients have mid-myocardium. Some patients have subendocardium. And some patients have diffuse and mixed pattern. And the localization of the LGE is also variable. We see that most of cases has inferior wall and septal wall LGE, but there's also scattered distributions in other territory. This is another surprise, that later gadolinium enhancement actually cannot predict MACE in our cohort. That the blue curve represent patient with a negative LGE, and the red curve represent patient with positive LGE, and their MACE-free survival is the same. When we look at the T1 value, we can see that patients with the T1 value below median have a better MACE-free survival, whereas the patient have T1 value above median has worse MACE-free survival. So T1 value is really useful in this setting. Subsequently, we also look at the use of corticosteroid in these patients, as this is, steroid is the mainstay therapy for ICI myocarditis. We can see for patients with high dose steroid, here it's defined by misoprostol greater than 500 milligram per day, is associated with the best outcome. And for intermediate and at the low steroid dose, there's a dose related reduction of the survival in these groups. And also timing of using steroids also matters. We can see that with patients who start corticosteroid within 24 hours, they have the best outcome in comparison to patients with time to steroid between 24 to 72 hours and the time to steroid greater than 72 hours. And this is a combination group between the high dose, the dose and the time of corticosteroid. The blue curve represent the within 24 hours, the yellow represent 24 to 72 hours, red represents a late administration of corticosteroid. We can see when the steroid was given fast, I say less than 24 hours, the medium dose group, which is the solid orange line, actually can achieve the same outcome as the high dose group was given late. So this actually tells us if we give corticosteroid fast enough within 24 hours, we don't have to give that high dose. We can achieve the same outcome for these patients, which we all know that corticosteroid has notorious side effects. And also in these patients, we're not sure whether steroid can actually suppress the anti-tumor, the anti-cancer effect from immune checkpoint inhibitors. So, you know, this study is very useful in telling us that giving corticosteroid fast is the best approach to go. We also proposed a diagnostic algorithm and a therapeutic algorithm for these patients for the time of interest. I'm not going to go over these details. But overall, you know, checkpoint inhibitor posed new challenging for us. I think for the high risk patient who has multiple cardiovascular risk factors, who's on ICI combination therapy, which has been consistently shown pose higher risk for these patients, and the patients already have a history of immune-related adverse events, they should undergo a baseline assessment. And for the patient with extremely high risk, they can do troponin and EKG before every cycles of treatment so that we can screen these patients. But this has to be used carefully because myocarditis is not that common in these patients. It may actually can cause some false alert in these patients. So lastly, cardio-oncology is really fast evolving field with abundance of opportunities. Anthracycline and anti-HER2 therapies require regular surveillance with imaging. Preventive approach with ACE inhibitors and beta blockers are very promising. And there are ongoing clinical trials evaluating preventing anthracycline toxicity with statin. And immunotherapy posed new challenges in the diagnosis of management of cardiotoxicity. So that's with that, actually, thank you very much for your attention. And then I'm happy to take some questions.
Lili, that's a fantastic review of cardio-oncology, and congratulations on your work in the immunocheckpoint inhibitor therapy and related myocarditis. So, I don't have any questions in the QA, but I have a lot of questions. So forgive me, I'm going to raise my questions first. And if you have questions, please type in. Number one, you have the algorithm prepared for us. And one of the important item you need to check off is the biomarkers. Now, for the troponin in the prior studies, the cardio-oncology community has been using high sensitivity troponin. Now, at Montefiore, what should we do?
So as far as I know, we're actually moving towards the high sensitivity treatment, but I don't know the timeline. So currently, we're still using our conventional technology, which I think is still very sensitive to detect the subclinical downside.
You're breaking up a little bit, Lili. Can you stay closer to the mic?
Yeah, I'm actually very close. Can you hear me better?
Oh, yeah.
Okay. So I was saying, yeah, currently we're still using conventional troponins in our institution. But even for the current troponin test, I think it's useful to predict myocyte injury or to detect a subclinical myocyte injury in this setting. I think the most important thing is to get a baseline troponin so that when there's issues happen, we can always compare and trend what it is, even though we're probably at different scale compared to high sensitivity troponins, but I think it is still instrumental to clinical care.
Okay, great. A question coming from Hashim. What is considered a clinically significant change in the LV global longitudinal strain?
Okay, so on the guidelines, it was defined as 15% relative reduction. So put in the scale, put in the perspective, if the patient have 20% of global longitudinal strain to start with, if they drop to 17% is considered significant. We all know that, strain has its limitations, where it has caveats when we perform the strain. We have to be very meticulous in the method so that the measurement can really means, can really be put in the clinical use. So I think it's important that we do standard strain analysis using the same vendor and using the same method across the studies so that we can compare the follow-up study to the baseline study. The short answer is 15% of absolute reduction, but this has to be done in a very standardized and meticulous way.
So just a quick correction, it's 15% relative reduction. So if you have a baseline of a minus 20%, you need to have more, impairment of your LV global longitudinal strain with more than 3-point difference. But, knowing how these strains are performed, it's really difficult to ascertain that these changes are real or just technically related. I've observed that cessation of chemotherapy has always been driven by reduction in ejection fraction clinically. There's no oncologist in our institution has made decision to stop chemotherapy because we reported a very big difference in strain analysis. I don't think currently we're mature enough to rely on strain. Maybe down the road, there will be more data and more reliable measurement of strain coming out.
Yeah, I completely agree with you that we shouldn't rely on strain to stop chemotherapy. I think even for ejection fraction, we have to evaluate thoroughly to make sure that the variable in the ejection fraction assessment is is consistent or it's only it's clinical meaningful. So very important to cross-rate the follow-up studies with the baseline so that you can get a good comparison and really to determine the reduction of the ejection fraction is really very important.
Great. We have a very good question from Rashna. She's wondering, in cases with no delayed enhancement on cardiac MRI, would you recommend proceed with endomyocardial biopsy in a hemodynamically stable patient?
So I couldn't go over the diagnostic algorithm because of the interest of time. But based on the experience from MGH, and I also discussed with Tom multiple times, we think we should have very low threshold to proceed with biopsy in these patients, because not only we're committed the patient to high dose steroid treatment, some immunosuppressant for up to 3 months or even longer, we're actually going to make a critical decision on stopping the ICI treatment. And some of them could be life-saving for these patients. And so clarifying the diagnosis, it's very important. I know, probably different institutions have different threshold and comfortable level of performing biopsy, but I think this is truly the gold standard for diagnosing myocarditis.
Wonderful. A question coming from Dr. Menegas. He commented on a great talk, and his questions are, for the ICIs, it seems to be a very broad spectrum of therapy. Are more specific inhibitors up and coming in the field?
Yeah, there's currently 7 agents approved as monoclonal antibodies to the immune checkpoint inhibitors. The 3 targeted points, including program DEF1, PD1, PDL1, and CTLA4. There absolutely more upcoming. As I mentioned, there are over 3,000 clinical trials being conducted right now to test these agents. So there's certainly going to be a new challenge for our work.
Great. Something that I've been interested in, I want to raise the question with the group in the remaining few minutes. We have a lot of childhood cancer survivors who reach childbearing age. Can you elaborate on how they fare during pregnancy? As everyone knows, pregnancy is a stress test. After they've been stressed as a child during cancer treatment, can they survive, and what's their odds to maintain their LVEF?
Yeah, thank you, Dr. Tom. This is a wonderful questions. I actually remember that you have discussed one patient with me in your clinic. This is actually very challenging. As I mentioned, the childhood cancer survivors are 500,000 nowadays, and they lots of them had a cardiotoxic treatment and radiation therapy in the past. There are a few small retrospective studies that looking at these patients for their pregnancy outcomes. Most of the studies suggest as long as their ejection fraction is back to normal, they pose similar risk as their other age-matched group. But if their ejection fraction is low, then the risk of pregnancy related complications will be much higher.
Great. It would be nice we could summarize our Bronx experience and observe, because I think our demographics is somewhat different from the published trials in the past. One last question. You spoke about primary prevention. How about secondary prevention? what are the guidelines for treating these patients who survived the prior cycle of chemotherapy with evidence of cardiotoxicity? What happens next?
So they should, for patients with reduced ejection fraction, they should put on the guideline directed heart failure therapies, including ACE inhibitor, beta blockers, or spironolactone or anthracycline. Based on their really, I think should be aligned with the heart failure guidelines nowadays. But I think for the patient with cardiotoxicity, I would advocate to start these therapies early, because we all know that anthracycline can lead to irreversible myocyte injury and death. And once it's to that point, it becomes irreversible, regardless what medications we put patients on. So I think our threshold, or my threshold, of starting these patients on ACE inhibitors and beta blockers are quite low. As long as their blood pressure and heart rate can tolerate, I would start rather early rather than late. And the statin is very promising in this field. There are 2 upcoming clinical trials in lymphoma patients and breast cancer patients. So I really look forward to see the results.
So these recommendations are extrapolated from other cardiomyopathy patients. Specific recommendations are lacking at present time.
Mm-hmm.
Yeah. Okay. So on that note, I think we're running out of time. Thank you so much, everyone, for your participation. Thank you for your great presentation and participation. And this concludes our evening grand round. I will close the session. Have a good evening. See you in the morning.
Thank
Bye.
you. Thank you, everyone. Bye.